Hello everyone, this is Shelly Reyes from CVI 2025, coming to you from Austin. I'm very privileged to be with Dr. Jacqueline Tamis Holland to talk about the new guideline that came for ACS management with ACS. Dr. Holland, thanks for being with us. Thanks for your time. Congratulations for the new document.
Thank you.
So let's go over some highlights of the document and in terms of the new change in practice that we're doing now.
So it's definitely been a very timely need for a new document. It had been about 10 years since the prior ACS guidelines. And about 10 years ago, we had both STEMI and non-STEMI. So I think one of the biggest changes was the combination of non-STEMI and STEMI into one document.
Yes.
And I think it makes sense because a lot of the evaluation is immediately you should do an EKG regardless. And then once you have your EKG, it's about how timely you need to be with your PCI. But ultimately, most people get revascularization regardless of STEMI or non-STEMI. And then afterwards, the management is very similar in terms of the antiplatelets and the medical therapies after an acute MI. So it makes sense to combine.
Absolutely. Is it a drastic change in terms of duration with the new iteration of antiplatelet therapy, in terms of duration of the antiplatelet therapy?
Yeah, so we have a really nice section on antiplatelet therapy, and we talk about sort of the default strategy, which is 12 months of DAP. But then we go on to give sort of other strategies for reducing bleeding risk, which of course is the usual 1 to 3 months of DAP followed by ticagrelor monotherapy, which had been discussed in prior guidelines, but I think was a little bit more focused on ticagrelor specifically. We also talk about just reducing DAP after 6 months for high bleeding risk patients, and then just going aspirin monotherapy. And then there's some provocative information based on super high bleeding risk patients to potentially stop one of the antiplatelets, potentially even the P2Y12, after 1 month in the super high bleeding risks. I think we kind of didn't feel that was too strong a recommendation.
I think also one of the highlights is the MCS use in ACS.
Yeah. So I am extremely happy with the decision we made with a 2A recommendation. I think there's a lot of questions. Should it be a 1? Should it be a 2A? And I think we clearly see some fantastic results in the DANGER trial in terms of improving mortality. But I do think that this was a select group of patients, and while the inclusion criteria allowed for blood pressures of less than 100 and lactates in the 2 range, in actuality, the patients enrolled in this study really had much higher lactates and much lower blood pressures. So to say that anybody with an acute MI and shock should get Impella, I think it's reasonable to say as a 2A recommendation that in select patients, it's reasonable to do.
Absolutely. Well, this is a great document. Again, I would refer to the audience to go to it, but this is a kind of highlight. Thank you so much for your work with the team, Dr. Holland. Watch the videos and others on the YouTube channel. This is Shelly Reyes coming to you from CVI 2025 in Austin.